next presentation is the pre-recorded presentation from Dr. Wael Alqarawi. Wael did his medicine and cardiology training in Canada before doing his EP training at the Ottawa Heart Institute, and worked there as well for a year before returning to Saudi Arabia, where he now is an electrophysiologist at the King Saud University Medical Center in Riyadh. And is director of the National Center for Sudden Death in Saudi Arabia. He's also an assistant professor at the College of Medicine at the King Saud University and remains an adjunct professor at the University of Ottawa. So I will allow Wael to talk about the paper.
Really delighted to present this study to you today. Sorry I couldn't make it live due to time difference, but I'm glad I was able to pre-record it. So the study was titled The Prevalence and Characteristics of Arrhythmic Mitral Valve Prolapse in Patients with Unexplained Cardiac Arrest. As a way of introduction, there was growing evidence that MVP is associated with cardiac arrest. However, there are two issues with previous literature. First, the prevalence of MVP was reported to be anywhere between 2% and 41%, and appeared to be dependent on the extent to which alternative diagnoses were ruled out. So if you look at all comers, all cardiac arrest patients, the prevalence of MVP was reported to be 2%, which is similar to the prevalence of MVP in the general population. And it was reported to be as high as 41% in a single center study, where extensive evaluation was made to rule out alternative causes. The other limitation is the lack of any control group to assess features of arrhythmic MVP as opposed to features of MVP in general. And I'll discuss that more in the coming slides. So the objectives of this study was to assess the prevalence of MVP in patients with initially unexplained cardiac arrest using a multi-center registry, and to compare characteristics of MVP patients with and without alternative diagnoses using pre-specified standardized criteria. So we used the CASPER registry, and as you know, CASPER enrolled initially unexplained cardiac arrest patients who then underwent extensive evaluation to look for causes of cardiac arrest. When no cause identified despite the extensive evaluation, the diagnosis of idiopathic VF was made. For this study, we reviewed echo reports for all patients to look for MVP. We then divided MVP patients into two groups. First is arrhythmic MVP, when patients were diagnosed with IVF and had MVP, and non-arrhythmic MVP or MVP plus in patients with MVP but an alternative diagnosis for cardiac arrest. And the thinking is that MVP might be an innocent bystander in these patients. We then, in patients who had available echo images, these echoes were reviewed by experienced echocardiographers, blinded to group allocation using pre-specified standardized definitions for all MVP-related echo features. The first important finding was the prevalence of MVP, which we found to be 7%. So 7% of idiopathic ventricular fibrillation patients had MVP. We also found that the prevalence of MVP in those with alternative diagnoses to be 2%, which is identical to the prevalence of MVP in the general population, and reported a significant association between MVP and IVF. The second important finding is the description of arrhythmic MVP. This is a busy table. There was really nothing different than what was previously reported in these patients. These were mostly females. They frequently had T-wave inversions in the inferior leads, often have frequent PVCs and Holters. Most of them had bileaflet prolapse, and many of them had mitral annular disjunction on echo. So there was really nothing different than what was previously reported. However, we had the privilege of having a control group of non-arrhythmic MVP. So we compared characteristics. And I note that the number of patients is small in the non-arrhythmic MVP, only 9 patients. However, despite that, we found a significant difference in the prevalence of bileaflet prolapse. So 78% of the arrhythmic MVP had bileaflet prolapse versus 12% the non-arrhythmic MVP. We also found a differential prevalence of family history of sudden cardiac death. So 24% of arrhythmic MVP had family history of sudden cardiac death, and none of the non-arrhythmic MVP, although this was not statistically significant. We also looked at their follow-up data when it comes to ICD therapies, including ICD shocks and ATP therapies. Red is arrhythmic MVP and blue is IVF patients. There were numerically more ICD therapies. However, this did not reach statistical significance. So the first point I wanted to discuss is the prevalence of arrhythmic MVP. The only other study that looked at this was the Mayo Clinic study that reported 41% prevalence of MVP in IVF patients. And I think the difference is probably related to our larger sample size and the fact that this is a multi-center registry with less potential for selection bias. Also, this 7% is similar to autopsy studies that reported the prevalence of MVP in patients with otherwise unexplained sudden death. The other important thing is the association with IVF. Although this was suggested by the overrepresentation of MVP in previous case series, this was the first study that proved this association with a significant p-value. In other words, the prevalence of MVP is significantly higher in idiopathic VF than in cardiac arrest patients with an alternative diagnosis. The other important point to discuss is the yield of evaluation in unexplained cardiac arrest. This was not different in patients with or without MVP, meaning if you look at patients who had initially unexplained cardiac arrest and you do the standardized evaluation, the yield of finding a diagnosis was not different. It was 27% in MVP patients and 37% in non-MVP patients. The clinical implication of that is that one should not presume MVP to be the cause of cardiac arrest without performing the extensive evaluation, at least until we have clear defining features of arrhythmic MVP. One cannot be 100% sure that the MVP did not contribute to the cardiac arrest, of course, in the MVP plus group, but the fact that the prevalence was identical to the prevalence of MVP in the general population truly suggests that it was just an innocent bystander. The other interesting finding from this study is the family history of sudden cardiac death being a potential risk marker for arrhythmic MVP. As I mentioned, there's a clear differential prevalence between arrhythmic MVP and MVP plus. This high prevalence of family history of sudden cardiac death was actually previously reported in the international collaboration study of arrhythmic MVP patients. Those are MVP patients who had unexplained cardiac arrest. But due to the lack of control group in previous studies, this was not pointed out as a potential marker. Obviously, future studies need to confirm this observation. Few limitations of the study. First, there was no core lab for MVP diagnosis. However, as you know, in CASPER, all centers are tertiary centers with expert interpreters of echoes. We also, when we were able to obtain echo images, these were reviewed by expert echocardiographers. And I must say, I think there was only one difference between in the 14 echoes where we had images, the report was identical to the blinded review, with one exception where I think it was reported to be bileaflet, but it was changed to unileaflet by the blinded review. The other limitation is the small sample size, relatively speaking. However, this is the largest cohort of initially unexplained cardiac arrest that examined the arrhythmic MVP patients, and the first that had control group. Perhaps some of the features would have been statistically significant if we had a larger sample size, but this is an initial step to suggest some of these features that could be examined in future studies. Thank you very much for the opportunity, and I also want to again thank all the co-authors for their help.
So Wael was kind enough to send us that presentation at the beginning of the week, which gave Simon and I a chance to review his slides. And at the beginning of this session, of this question part of the session, we posed a few questions to him by email, and he very kindly recorded an additional section where he responded to our questions. So we'll hopefully load that up, and that will hopefully give you some extra time to think of any audience questions, if you could want to present those in the chat or raise your hand at the end. And Dr. Kranz kindly agreed to field any live audience questions.
The first question is, hello again. Thanks, David and Simon, for the questions. Sorry for my voice, I'm just recovering from flu, but hopefully it's clear enough. The first question is, given that 24% of cases of arrhythmic MVP have a family history of sudden cardiac death, how does a positive family history factor in your approach to risk stratification in such cases? I think obviously we need more data, but I also think it's fair to use family history of sudden cardiac death as one of the features suggestive of arrhythmic MVP, just like bileaflet prolapse and MAD and late GAD, T-wave inversions and Wayfair leads. So practically speaking, if I see someone with MVP in a family history, in a first degree relative with unexplained sudden cardiac death, I would be more likely to do more extensive evaluation with MRI and extended monitoring. I also would offer screening, family screening for MVP. But as I said, this is early. This is just an observation, and we need to confirm that family history of sudden cardiac death actually risk stratify these patients. Next question, in cases of arrhythmic MVP with a family history of sudden cardiac death, do we know whether postmortem examination had shown evidence of MAD, slash MVP in the deceased relatives. Yeah, that would be great. To my knowledge, I'm not aware of any study that looked at that. And this is one of the limitations. We actually don't know if this if this family history of sudden death is related to MVP or not. Last question, bileaflet MVP was found in the non-arrhythmic MVP group in this study. How would you counsel patients as to the significance of bileaflet MVP in the context of an alternative diagnosis for their cardiac arrest? Yeah, that's a great question. So I'm just going to show you a slide from the recent review article where we proposed an algorithm to unify the terminology used in patients with unexplained cardiac arrest and MVP. So if you see someone with unexplained cardiac arrest and MVP, you should do the extensive evaluation as always. And if everything is negative, no alternative diagnosis, and the patient has MVP, then we suggested using the term definite arrhythmic MVP for that patient. But if there's an alternative diagnosis for the arrest, then we look at features that are associated with arrhythmic MVP, such as bileaflet prolapse, MAD, frequent PDCs, and family history of sudden cardiac death. And if that patient has any of these, then we suggested the term probable arrhythmic MVP. If none of these features was there, the patient has and the patient has alternative diagnosis, then we suggested using possible arrhythmic MVP. Obviously, these features might change in the future as we know more about the defining features of arrhythmic MVP. But at least for now, this should help standardize the terminology in these patients. Thanks again, and I look forward to seeing the whole session recorded online.
Thank you again to Wael, although he's not here. I think he's planning to watch this back on video later. So we're very, very grateful for you speaking, Wael. Thank you. This is where we'd normally open up now to the floor. I don't see any raised hands, and I don't see any other questions in the chat. Now would be a good time if anyone has a question they'd like to ask. I can see that Andrew has reappeared, so thank you, Andrew. Andrew, if I may, from your side, how do you approach these patients when you see them in clinic? You know, unexplained cardiac arrest, presence of mitral valve prolapse, maybe MAD. What are you doing with that patient and then with their wider family as well?
Yeah, it's a good question. You know, practically speaking, I think we've been talking about this whole idea of sort of strength of diagnosis and then how you counsel patients for years around a bunch of different things. And I think I'm the one who originally sort of coined this concept of a working diagnosis. So for now, if you make me vote, I'm going to pick MVP as the best explanation or the biggest contributor. You know, recognizing oftentimes these things are a perfect storm of a bunch of factors, the most evident of which is the prominent diagnosis. So if it's long QT or whatever. So from their perspective, you know, they need valve surveillance for development of the structural elements that lead to progression and valve intervention. And you know, concurrent with this, hopefully, you know, there's so much going on in mitral valve, you know, repair, catheter aversion, you know, things in the future that will help to extend the durability of prolapsing valves and so on. So, you know, you need a valve partner about that management aspect. From a family screening perspective, it's a real pickle. You know, I'm always reminded of somebody who I met who had actually sudden death with MVP, whose daughter is a physician and patient of mine, who we banter about this frequently, and I lean on her with MVP, negative genetic testing, not much disjunction, no like mild to moderate MR, no LV dilatation or heart failure, and saying, you know, there is some risk. I can't be quantitative about it, but it does make me slightly unsettled. But on the other hand, an ICD would be an invasive approach in a young woman. So, you know, I think, I hate to use the overused term shared decision making, but you have to, I think you have to convey your uncertainty in that situation when you find a family member with a phenotype. But without a phenotype, I'm quite reassuring.
Yeah, that's a great answer. Thank you. Thank you for the insight. Let's see. No other questions there. Dave, did you want to ask anything or any questions?
Well, I think Andrew kind of mainly answered the question that I was thinking of. I guess I was wondering, in my mind, if we had any data at all on the yield of systematic screening in these patients with the arrhythmogenic MVP, and whether or not, if we don't, that Casper might have some data on that.
Yeah, we haven't, you know, when we've talked about who should be a HiRO and stuff, we've talked about the question of whether we should, you know, take the phenocopies and the apparent things and enroll them. And so sarcoid was an original conversation about what that too, because it's an ARVC mimic, right? Or typically, or an infiltrative cardiomyopathy like a lamin A is an example. So, so I think the short answer is it would be interesting to assemble a cohort of arrhythmogenic MVP or cardiac arrest patients, but you've seen the scope of what we have, which is pretty modest because our lens starts with the unexplained cardiac arrest and not the other way around. There has been discussion about that, about creating a national registry by some people who are more valve-focused individuals, but I'm not aware that went anywhere.
No, that's great. Thank you. If there's no